This is my first time doing a webinar, so I'm hoping that it runs smoothly. Can you guys hear me?
Yeah.
Cool. That means I'm doing the lock talk properly. That's a good thing. My name's Todd Duhamel. I'm a researcher from the University of Manitoba, and I'm based out of the St. Boniface Hospital Research Center. My primary research interest is looking at cardiovascular health in both animals as well as human patients, because we do a bit of clinical work with the hospital group here. We focus on cardiac rehab a bit, but a lot of the work we do is physiology-based, where we look at animals. Now, you may wonder why an animal researcher is talking to you about this topic today, but my primary interest is using physical activity interventions. So clearly the work that we do with animals can really be used to guide and inform physical activity interventions with humans as well. And the other interesting part about doing animal work is that we actually look at a lot of the mechanisms that are turned on by exercise to promote health and hopefully improve the patient's overall health if they can be more active. So just generally, I'm hoping to talk about 40 minutes today. There seems to be quite a few slides, but the way I've organized them is that to be able to have things pop up on the slides, there's just a few slides that are involved in moving through it, but hopefully it'll have a nice flow. The learning objectives today basically boil down to this series of questions. So why is diabetes a major health issue, challenging the well-being of Canadians? Why should healthcare practitioners be interested in physical activity? Does a lack of physical activity contribute to the incidence of diabetes? How much activity does someone need to improve their overall health? I'll briefly talk about some of the mechanisms that are turned on by exercise to promote health, because I think it's important that we have a basic understanding of that. And then try to wrap up with some perspectives on healthcare systems and how the Canadian healthcare system can adapt to support patients adopt a more physically active lifestyle. And really, from a practitioner perspective, that's an important thing. I'm just trying to wait for the slide to load up here. So this takes us to the first question of why diabetes is a major health challenge in Canada. Okay, as a lot of us know, there's generally three major classifications of diabetes. First one being adult onset type, or youth onset diabetes, or type 1 diabetes. Traditionally, this has been viewed as juvenile onset, and the primary dysfunction is pancreatic beta cell dysfunction. Becoming more clinically relevant in adults or adult onset type 2 diabetes, the primary defect is actually at the level of the tissue, where insulin resistance is the primary concern, and eventually when it becomes overt diabetes, pancreatic beta cell dysfunction happens. Now, in pregnant women, gestational diabetes can occur, and the prevalence of gestational diabetes is increasing significantly around the world right now. And the reason that this is such a clinically relevant form of diabetes, even though it's relatively rare compared to the other two forms, is that the fetus, when exposed to high glucose in utero, they have a 5-fold increased chance of getting diabetes later in life. And in some populations, it can be as high as a 20-fold increase depending on genetic background. So if the mother becomes gestationally diabetic, the fetus, when it becomes a child, may actually become diabetic at a much younger age, and the risk for that child to become diabetic is massively increased. Now, regardless of the type of diabetes, what we know is that they all three of them have metabolic abnormalities that eventually lead to pathological complications that impair health.
Congratulations. If you could hear this message, audio.
So, being practitioners, I imagine a lot of you know the diagnostic criteria for diabetes. Typically, an oral glucose tolerance test is used to be able to diagnose people that may be diabetic. And typically what we'd expect in a healthy, normal person, glucose after no fasting blood glucose levels would be 4 to 6. If they're impaired fasting glucose levels, it would be between 6 to 7. And if they're fully impaired glucose tolerance, it'll be or they're fully diabetic, those would actually be higher than 7. And if they do the OGTT after they take a 75-gram drink of basically sugar drink, come back in 2 hours later, we would expect to see in diabetic people that glucose is actually above 11 millimolar, whereas in the normal condition we'd expect it to be less than 7.8 millimolar, and that's an important indicator. Now, when we look at these kind of measures of just fasting glucose, it's really a snapshot of what the condition the person is under at that time. Another measure that we can use is glycated hemoglobin, so HbA1c, and it's measured in percent. Now, what we know is in most individuals, the glycated hemoglobin percentage is below 7%, whereas in diabetics it tends to be above 7, and the higher it is, the worse it is for the patient. Specifically, if we look at HbA1c, what it really is it's the red blood cell content that you have and the amount of glycation end products that are on the red blood cells. And what those glycation products are is the higher the blood sugar has been for the last 3 months, the more glycation is going to be on the red blood cell, which causes our HbA1c to go up. So for every 1% change in glycated hemoglobin, the HbA1c, we see that cardiovascular risk can be changed or modified by 21%. So a person that has a glycated hemoglobin of 7 has a 21% higher risk of cardiovascular disease than somebody that has an A1C content of 6%. And that's significant because that's a 21% increase. If we take it out of cardiovascular disease and we look at their chance of death or mortality, we see that a 1% change in HbA1c can be related to 21% change in mortality, a 14% change in risk for having a heart attack or myocardial infarction, or 37% higher risk or different risk for microvascular complications. And so it starts coming out that this glycated hemoglobin, or the content of sugar in your blood for the last 3 months, how it affects your red blood cells, can actually be directly related to cardiovascular disease. Therefore, there's significant prognostic value to use an HbA1c as a diagnostic tool. Now, a lot of us will know that diabetes the prevalence has increased significantly, and these 3 graphs basically illustrate the problem that we're facing. In the year 2000, there was about 171 million people in the world that had diabetes. That number is estimated to be 350 million by the year 2030. In Canada, currently more than 2 million people have diabetes. It's estimated to increase to 3.5 million in the future. And if we look at Ontario-specific data, there was an interesting study done by Lipscomb et al. And what they showed is that if you look at the yellow bar on the right, it's the predicted value that was supposed to be in 2030, which is the same timeline as the world and Canada data. But the actual number of people that had diabetes in 2005 in Ontario was greater than 800,000 patients. So in 2005, there was actually more diabetic patients in Ontario than what we're predicting for 25 years later. So some of the estimates on the worldwide or the Canada data on the left are probably dramatically underestimated, which really says that the healthcare system is going to be most likely unprepared for the number of patients that they're going to have to deal with that have diabetes and its associated clinical complications. Now, in Manitoba, we have a particular problem where we are also seeing increases in diabetes over time. So the graph on the left basically shows male and female data in blue and pink, and you see that the number of cases is going up significantly over time in the last 20 years. But if you look at the graph on the right, what we look at is at the prevalence based on age. And we actually see that on the green and red lines, those are the data for males and females. And we see that the rates are going up according to age, which we'd expect if type 2 diabetes is a major problem, and in Manitoba it is. So people that are between 40 to 60 are tending to get diabetes more often. But interesting, we're seeing an increase in diabetes at much younger ages, which I'll talk about a little bit later. Now, I also wanted to draw your attention to the blue line. It's on the right-hand graph there. The prevalence of diabetes amongst First Nations or First Nations peoples in Manitoba is disproportionately high. And given that Manitoba has one of the largest proportions of First Nations in population in Canada, our healthcare system in Manitoba is being incredibly challenged by the prevalence of diabetes, both amongst young and old people, but also amongst First Nations communities. Now, we all know that diabetes is a systemic metabolic disease, but the most important clinical complications that actually lead to death and hospitalization are all cardiovascular diseases. So stroke, heart disease, kidney failure, peripheral vascular disease, or foot and leg problems, which typically lead to amputation, are some of the major clinical complications that end up costing, impairing somebody's health, but also costing the healthcare system. Now, with my research interests, we're interested in the cardiovascular diseases and heart disease specifically, but we know, based on some epidemiological data, we know that the risk of a diabetic person developing heart disease or cardiovascular disease is 2.5-fold greater than what we'd see in normal people. So clearly diabetics are under some sort of disease mechanisms that preferentially influences the cardiovascular system. So therefore, we need to consider cardiovascular disease anytime we do treatments for patients that have diabetes. This graph shows that the take-home point here is that 80% of diabetic patients die from cardiovascular complications. And interesting, heart disease is the largest complication of all the different types of cardiovascular disease I described in the last slide. So we know that roughly 5% of Canadians right now, or Westerners, have diabetes, but 25% of those diabetic people actually have heart disease, as indicated by left ventricular dysfunction. So the way that the heart contracts is actually impaired in 1/4 of all diabetics. That's significant. Moving forward, what we know is if we look at, or actually looking backwards is a better way to say it, if we look back over the last 30 years, we know that the number of people entered into hospitals due to heart disease and amongst the diabetic population has actually increased 4-fold. So this is showing us that not only do a lot of diabetic patients have heart disease, but a lot of them are going to the hospital, and a disproportionately larger segment of this group is now entering the hospital today versus how many people were entering the hospital for the same reason 30 years ago. So this is telling us that there's probably been some sort of behavioral change or disease mechanism that's been activated to impair their health to a much greater extent today than what we were seeing just 30 years ago. Just waiting for the slide to update here. Another slide I just want to show you was the mortality rates here. People that are generally healthy, of course, they're going to have some adverse events sometimes, and their mortality is going to be impaired over a 6-year period. But if we look at people with cardiovascular disease or just diabetes, we see the death or survival rates of these patients are actually very similar. But when we identify patients that have both cardiovascular disease and diabetes, which is indicated in the yellow box here, that survival curve is significantly worse. So what it tells us is that diabetes is bad, cardiovascular disease is bad, but patients that have both diabetes and cardiovascular disease, their survival is much, much worse. The comorbidities themselves are going to be costing that person their health significantly, and also costing the healthcare system significantly. So in Manitoba, we have approximately 78,000 diabetics out of our 1.1 million people. But interestingly, the diabetic patients tend to spend 3.5 times as many days in hospital as the average Manitoban that needs to be hospitalized. More importantly, from a healthcare perspective and a cost analysis, is that the 76,000 Manitobans that have diabetes, we expect to spend about $295 million in the year 2016 to be able to treat these people. So on a per patient basis, or from a tax basis, the drain on the Manitoba healthcare system is incredibly high. And I'm not sure how it is in Ontario, but I would expect it to be very similar. Interestingly, even though the looking forward at the diabetes estimations, it seems that we're really getting in trouble. We actually may only be seeing the leading edge of the epidemic that's coming, because in particular in Manitoba, type 2 diabetes is a major growing concern in children. And if children are contracting or are becoming type 2 diabetic at a much younger age, that means that one of two things is going to happen. Either they're going to have heart attacks at a younger age because they've had diabetes for a much longer time, and that's going to drain the healthcare system and also impair their personal health. Or there's a possibility that they may actually not have more cardiovascular events until much later in life, but the treatments that they require before they get to that point are going to be required for a much longer time. I tend to favor the first, where they get diabetes at a younger age. The high glucose and metabolic problems they have lead to cardiovascular disease at a younger age. So traditionally, where most people that got type 2 diabetes were in their 40s and 60s, we're seeing a larger proportion of children coming in that actually have diabetes. And this slide indicates that. In 1980, between 0 to 4% of all cases in Manitoba of diabetes were the type 2 form. Everything else was a type 1 juvenile onset diabetes. In the year 2006, we actually see between 8 to 45% of new cases of diabetes being diagnosed as a type 2 diabetic situation. Now, you may say 8 to 45%, that's a pretty big window. The 8% tends to be children that come from a European background, whereas the 45% of children being diagnosed with diabetes, they tend to be the ones that are from the First Nations. So clearly, diabetes amongst youth is a growing problem. And it leads to the question of why does this happen? And one of the things we found through a Manitoba in Motion research group is that less than 10% of Manitoba teenagers or adolescents currently meet the physical activity guidelines in Canada. That's significantly low and really worrisome, because it means that 90% of children or teenagers that should be running around playing are actually sedentary. Something's changed in the environment or in society that's caused them to stop being active. So it leads to the next question is, why should health practitioners be interested in physical activity? Well, I think there's a lot of different reasons. The first one is as health practitioners, we're all relatively aware about different chronic disease risk factors. So obesity, high blood pressure, dyslipidemia, stress, depression, and smoking can all lead to different chronic diseases. And we probably have a decent understanding that physical activity or insufficient or a lack of physical activity is also a risk factor. But probably what's generally less known is how important a lack of physical activity is as a risk factor. So this slide here shows that the number of people that are actually at risk of high blood pressure is only about 10% of the population. People that have high cholesterol, again, is only 10% of the population. Smoking is about 20%, unfortunately. But people that are insufficiently physically active, or the number of people in Canada that do not meet our physical activity guidelines, is actually closer to 60 to 70%, depending on what region of Canada you're looking at. So 60% of Canadians are at risk for becoming sick because they don't participate in enough physical activity. That's a major difference from all these other risk factors when you look at the magnitude of people at risk. Okay, and if we look at different age data, this is a U.S. data set, but Canadian ones are very similar. We see that 18 to 29-year-olds tend to be more active than their older counterparts. So people that are over 65, you see the yellow section of the graph, the inactive portion of the graph growing. And that's part of the reason that chronic diseases set in at an older age. Part of it's just the aging process too, but importantly, across age differences, we see differences in how many people are actually physically active. A lot of it's probably related to jobs and what we do at school and things like that, where youth are probably more active generally. It leads to the question, though, is does a lack of physical activity contribute to the high incidence of diabetes? And there's some really cool data out there, and I like citing the diabetes prevention program. But before I do that, I want to draw your attention to there's really only 3 ways to be able to modify diabetes risk or to actually have an intervention for diabetes. And the 3 of them really are is sufficient physical activity, so promoting a more physically active lifestyle, promoting proper nutrition, so changing people away from junk food to healthier foods and vegetables and things, appropriate portion sizes. And then the last one is pharmacological interventions. And clearly metformin is a very effective drug. So in this diabetes prevention program, what they looked at is they had three groups of people. One was basically given a placebo, and they looked at the percentage of people, the relative incidence of diabetes amongst this group. And you see that it increased over time. They then gave one group of people that were at risk for becoming diabetic metformin, and what they saw is, compared to placebo, 31% less people became diabetic after 3.5 years of being on metformin. Okay, and then finally, the third group that they compared was a lifestyle intervention, which was a combination of physical activity interventions plus appropriate nutrition interventions, so a lot of behavioral change work. And what they ended up seeing is that the incidence of diabetes was actually reduced by 58%. So the take-home message from the diabetes prevention program is that lifestyle interventions work incredibly well and actually may be more effective over the long term than a pharmaceutical intervention. Now, this data does not discount the possibility that if we would have given lifestyle interventions plus pharmaceuticals, that even more of diabetes would have been reduced. But it does tell us that lifestyle interventions are really good. So some additional data to support this perspective is, if we want to focus on the physical activity aspect, if we look at sedentary behavior as a major risk factor for type 2 diabetes in adolescents or youth, what we see on the graph on the left is risk scores for physical activity, or risk scores for diabetes. And on the x-axis on the bottom, we end up seeing that as physical activity goes up from 1 to 5 on the scale, the people that were more physically active on the right had a lower risk score for diabetes. And if we look at the risk of metabolic disorders amongst another group of people, we again see that the more physically active people are, the lower their risk for diabetes is. So clearly, more exercise is better for us for preventing diabetes. Okay, now, this study that I'm going to outline here is really, in my opinion, impressive. And it basically asks the question is, can physical activity prevent diabetes in someone who has a genetic predisposition for the disease? So if somebody comes or has two parents that had diabetes, is there any way that physical activity can prevent them from getting diabetes? Because clearly their family has a history of diabetes. And the good news is yes, it can. And I want to draw your attention to the blue lines here. The first blue line on the left represents the risk profile for the most inactive or most sedentary people that have a parental history of diabetes. And as we go from left to right on the blue bars, we see that the relative risk of type 2 diabetes goes down as a person becomes more active. And that's really, really important. We also, the graph in the yellow bars presents similar data for people that do not have parents with diabetes. So these people have no family history at all. And we see a very similar trend. The more exercise somebody accumulates, the lower their risk of actually becoming diabetic amongst people that do not have a family history. So clearly exercise is good for both people that have parents with diabetes and therefore have the genetic predisposition for diabetes, but also for people that otherwise don't have a family history of it. So exercise seems to be good. Now, to put this in context, these percentages are the differences we see. Amongst people that have a family history of diabetes, 35% of them, if they were highly physically active, would actually never become diabetic. And that's really important because if they have a genetic predisposition to it, physical activity can actually modify their risk of becoming diabetic. So clearly, the way that just because we have the genes that that may influence diabetes, by changing our behavior, we can actually have health benefits. So the people that are at most risk for diabetes can actually reduce their risk by 35%. And there's probably no pharmaceutical intervention out there that can claim that level of success. So physical activity clearly is good.
Please click next to continue.
Some additional evidence, if we were to count the number of patients that we'd have to see and treat with lifestyle interventions before we actually improved one case of diabetes, we'd see on the left graph here that based on the study by, that's outlined on the bottom, the references are provided on the bottom. But anyways, based on the study, we see that if we gave 6.4 patients a lifestyle interventions, we would prevent one case of diabetes. Whereas if we were to use pharmacology, different pharmaceutical agents, it would require 10.8 patients before we actually prevented one disease case. So clearly the effectiveness of lifestyle interventions is actually stronger than the pharmaceutical used in this study. Another really important thing to take away from this slide is that the incidence of diabetes 5 years after the intervention, so even if we do an intervention and we stop the intervention, 5 years later there's data showing that the incidence of diabetes is actually cut in half from a group that we never did the intervention with. And actually only 20% of people that did that short-term intervention actually ever become diabetic in this study. And that's really important because right there it tells you that perhaps a 4 to 6 month intervention actually has clinical effects. And it has effects long after the intervention was stopped. Because from a healthcare perspective, we're probably not going to be able to intervene for somebody's lifetime, but we may be able to do some sort of diabetes rehab program for 4 to 6 months, which then we send them on their own, and hopefully they've learned enough skills to be able to improve their health. And this is evidence to support that notion. So it leads us to our next question, and how much physical activity does someone need to improve their health? And really this is kind of a dose response question. Should somebody run longer, or run more, or run faster? What should they do? So I'm going to start out by giving you the the Canadian Diabetes Association guidelines. Just for reference, these are right from their website. And basically they tell people to accumulate 150 minutes of moderate intensity aerobic exercise each week, spread over at least 3 non-consecutive days, and also perform resistance exercise, which are 3 sets of 8 repetitions 3 times a week. So as you can tell, that was really hard to read. And it's probably relatively hard to understand if you're a patient. Because what does it mean, moderate intensity aerobic exercise or other things? So I'm giving these to you because these are the goals that practitioners need to keep in mind when they're trying to prescribe exercise. And there's a lot of scientific evidence showing that this prescription actually works. In a clinical setting, though, we're probably interested in something that's a little bit easier to be able to tell people, and I'll give you those messages in a few minutes. I just want to show you this data first. The reason that the CDA and other agencies, like the Canadian Society for Exercise Physiology, recommend that people do both aerobic exercise as well as resistance training, which is really strength training, is that the combination of the aerobic plus strength training is the most effective way to improve glycemic control and thereby reduce cardiovascular risk in these diabetic patients. So in this study, I believe this was a DARE trial that was done in Ottawa. What we see is if we take control people and we just follow them for the course of the study, we see that their HbA1c, which is the glycated hemoglobin, actually doesn't really change all that much. Okay, and if you remember earlier I talked about glycated hemoglobin, a 1% change is related to a 1% change, or a 21% change in cardiovascular risk. So these people that are in the control group, it seems their cardiovascular risk is at least no better, so they actually didn't improve if we didn't have an intervention, so that's good. Well, not good for the patient's health, but from an experimental standpoint, no change in the control group is what we'd expect. Now, people that did the aerobic exercise training, and that's all they did running on a treadmill, and basically what we ended up seeing, what the study saw was that there was a minus 0.4% change in glycated hemoglobin. So glycated hemoglobin was reduced by 0.4%. which if you do the math on it, that's a 10% improvement in cardiovascular risk. So these people are at risk of having a heart attack by at least 10%. Okay? If we then look at a different group that had an intervention where all they did was lift weights, so they did no walking or running intervention, all it was lifting weights in different kind of modes, and we see very similar kind of change, about a minus 0.3% change, so an improvement in glycated hemoglobin, which is again related to cardiovascular risk, but clearly lifting weights is equally as good as probably doing aerobic exercise. But where the most improvement was is when we combined aerobic exercise with resistance training. So you actually see about a 1% change or a 0.8% change in glycated hemoglobin, which tells us that there's about a 20% improvement in cardiovascular risk here. So the combination of aerobic training and strength training actually is beneficial. Now, from a healthcare standpoint, what's really important is that their health is improved, but it's also related to changes that we could probably do. This intervention worked, and the cost the cost of the program was actually about $130 a month for the aerobic group and also the resistance training group, and about $200 a month for the combination group. So as a cost analysis, it seemed that these programs are actually relatively cost effective. We improved cardiovascular health by 10% in this group. We improved glycemic control by 1% on the HbA1c scale. Those are clinically relevant changes at a cost of $200 a month. So there might be some sustainability in the program when we factor in how much pharmaceuticals cost, when we know a lot of the pharmaceuticals aren't this effective. Okay, and of interest, if you look at the CNN News website today, this article was just published. There's a brand new paper that was basically a follow-up to the study that I just showed you. And basically the take-home message is lifting weights plus walking causes you to become more fit in less time. And isn't that the real take-home message that we'd like to be able to do, or the magic bullet that we'd like to do? You get more physically fit with doing less. And interestingly, when they look at these diabetic patients that did the combination of walking plus weightlifting, they see that their A1C changed significantly, that the patients lost more weight doing the combination of both types of exercise than when they did either exercise alone. Okay, so here's a brand new study that just came out hot off the presses today and was picked up by the media. So I promised you that I gave you some common sense physical activity recommendations, and I really don't think that exercise prescription needs to be rocket science. In reality, simple messages are probably going to work the best. If you have the background where you can work with physical activity and you understand the parameters, clearly more detail is really important. But when we're communicating with patients, clarity is really, really important. So these are the general comments that I tend to make to people when we discuss what kind of intervention would be based on best practice. I don't actually work with many patients at our hospital because of a PhD background, but these are the things that I tell the people that do work with those patients. First of all, any physical activity is good, and the reason for that is that if we accept that people are most likely inactive when we see them, that if we can improve their amount of physical activity, that's a good thing. So maybe walking is really a challenge for somebody to do, especially if they've been diabetic a long time, their blood glucose levels are really high, they're obese, which a lot of diabetic patients are. It may be a challenge for them to get up and just walk around their house, never mind trying to go and run on a treadmill. So rather than tell them to run on a treadmill, it might be appropriate to tell them just to do any physical activity because it's going to be better than nothing. Okay? The next message I think is important is that more physical activity is better. Once this obese diabetic patient is able to get up and walk around a room or walk around their house quite a bit, telling them to get out and walk around the neighborhood is a good progression. And if they can walk for 20 minutes at a time, that might be an improvement from where they started. And then if they are able to walk 20 minutes, this recommendation works really well because you tell them walk for longer. And if they walk longer and eventually get up to 60 minutes a day, 3 days a week, they start meeting the Canadian Diabetes Association guidelines, which are really good gold standards to try to achieve. But this message is really simple, that no matter what they're doing today, more is always better. And this actually holds true for everybody, including marathon runners, because the best way to train for marathon is to run that distance and get used to doing high distances. So this message works for both sick patients as well as people that want to be elite athletes. A lot of the most current research is starting to look at the intensity of exercise. Is intensity important? And the take-home message is yes, it is. The more intense or harder you challenge yourself, the heavier you breathe, the more you sweat, actually leads to significant metabolic adaptations in skeletal muscle in a much faster time frame than walking does. It may not sound like rocket science, but it works. More intensity is better. So one of the things that Olympians do, and part of the own podium is that they were using high interval training methods, high interval sprint training, to be able to try to get people doing higher intensity. And these interval training methods work in Olympians. Interestingly, if we do a very similar high intensity interval training model with heart disease patients, so people that actually have heart failure, those patients actually adapt much quicker to the high intensity training than they do the walking programs. So we have to consider safety when we're telling people to do more intensity, but a really important message is if you're able to do something for 20 minutes at the pace you're going, maybe you walk faster. Or maybe you sprint for 1 minute and then walk for 1 minute to catch your breath, and then sprint again, and then walk again and catch your breath. That interval training of sprint, walk, actually seems to have increases in endothelial function, blood flow regulation, and other parameters that influence cardiovascular health. And it will work in diabetes, just as well as it works in our cardiac patients, and just as well as it works in our Olympians, believe it or not. Now, for most people, intensity is a hard thing to define. So what I would tell patients is that you want to exercise at a pace that makes you breathe heavy, or that makes you sweat, because sweating is good for you, believe it or not, because it tells you that you're challenging your body. The next important thing, and this is kind of a step back, everything so far has been telling people to be physically active or to exercise. And what we need to remember is that people will only be active if they're having fun. If they hate doing it, they're not going to go to the gym and work out. They're not going to walk around their neighborhood, or they're not going to ride their bike if they don't enjoy doing it. Interestingly, if we think about the children that I told you about, the teenagers that don't do anything anymore, they tend to be sitting and watching screens or hanging out with their friends, and they don't want to be active. But if they're having fun, they'll probably do it. So if they're playing a soccer game or a basketball game, they'll probably be having fun. They might not realize that that's actually physical activity that's promoting their health. And if we think even younger than that, if we think to children, what do children do in playgrounds a lot of times? One of the games they play is tag, which really is high intensity running to get away from somebody so they don't tag you, followed by a break where you're probably, teasing somebody so they do come chasing after you, so then you can sprint again to get away from them, and then you sprint, pause over and over again. So the natural way that children play is actually sprint interval training, and they're doing it because they're having fun. So this point of fun is probably one of the most important things, because if they're not having fun, they won't consistently come out, they won't change their behavior to get more activity in their life. And then this last one I think is really important. There's some cool research coming out showing that screen time has a negative impact on health. And if you think about it, you step back and think about it, the more time we're sitting in front of a television or a screen means there's less time to be physically active. So what if we remove screens from our life and therefore have nothing else to do? We're probably not going to sit in our chair and do nothing. We're probably going to get up and try to find something that's fun to do. And by accident, that means we're probably being more physically active than if we were sitting in our chairs looking at a screen. So one of the common sense physical activity recommendations is actually to reduce the amount of time sitting in front of a screen. And this is something that most people could chart how many hours a day they're in front of a screen. And instead of doing it for 8 hours a day, maybe they do it for 7 hours a day if they're able to, or hopefully get it down even more than that, depending on what their job is. So you may be interested in, what are the mechanisms that are turned on by exercise? A lot of us are familiar with drugs. We tend to understand that the drugs will activate different proteins in the body and influence the regulation of glucose through specific physiological mechanisms. Well, exercise does the same thing. And I can break it into a few different major classifications for you, which I'll do in a minute. But I want to present this concept to you first. If we think about optimal health, there's always going to be a certain amount of physical activity that we need to be healthy. And if we get less than that amount of physical activity, we probably fall into a stage of disease. So based on the Canadian Diabetes Association or the Canadian Society of Exercise Physiology group, about 4 hours a week is what we need between aerobic exercise and then also through the strength training. So if we get this 4 hours a week, we're probably going to be in an optimally healthy stage based on the recommendations. So the problem comes in from if we get less than that 4 hours a week is when we enter a stage of disease, which is shown here. If you get about 3 hours of exercise or 2 hours of exercise, you see that the graph of health actually drops off. But once you start getting below this 2 hours of exercise, we see that you have a faster onset of disease. So this concept is important, and it kind of comes back to my first point of the common sense recommendations that any exercise is good. Because any amount of exercise will actually get you closer to the optimal health stage than if you had 0 minutes of exercise. But what it tells us is if we're not meeting our physical activity guidelines, or this 4 hours a week, that we're going to be suboptimally healthy and actually in a stage of disease. And one example I use when I'm talking to my students at university is that if you had scurvy, which is basically a deficiency of vitamin C, you would probably fit into the disease portion of the stage. But if you were smart and you ate a lot of oranges or citrus fruits, you would get enough vitamin C into your body and you'd be in the optimal healthy stage. Well, the lack of physical activity is very similar to the lack of vitamin C in that the lack of both of these items leads to disease states. And usually when I show slides, I show a picture of a pirate on that because scurvy and pirates from the good old days, right? Now, the physiological mechanism of why any amount of exercise is good and why more is better is because physical activity directly influences signaling pathways in our cells that influence what genes are being turned on or off. So the more physical activity you have, the more you change protein expression at the cellular level. In this example, I've shown physical inactivity as a stimulus, so sedentary behavior. It goes in and affects the DNA, which is kind of drawn on that squiggly line. If the DNA is being expressed in a specific way, what may end up happening in sedentary people is it inhibits the health-promoting proteins in the body or activates disease-promoting proteins. Now, interestingly, physical activity itself is known to influence 385 genes in the body. So that is a lot of genes that are being turned on or off in response to exercise. So it's the balance of physical activity that influences these 385 genes that ultimately influence, are we going to be in a healthier condition or are we going to be in a disease condition? And if we're sedentary, we tend to promote the disease aspects, which ultimately lead to the clinical implications and reduced survival. So it's important to accept that exercise actually affects our genes. And if we think back to that genetic family history of diabetes, this is why exercise is able to actually reduce the risk of diabetes in people with a family history by 35%. It's a major influence that our genes are there, but they have to be instructed what to do by exercise or by other stimuli. Now, another really important thing to consider is the fact that, as we know with diabetes, insulin is a major problem. And insulin is a hormone that's released from the pancreas and acts on muscle and other tissues to be able to influence glucose. Well, these hormones are really important, and what I've shown on this slide is a bunch of different glands in the body or organs in the body that release hormones, and I've listed a lot of different hormones that are actually associated with those structures. What we've known now with the most recent research is that skeletal muscle is actually an endocrine organ. So hormones are specifically released from muscle to be able to go into the cardiovascular system, the vasculature, and signal the brain, the liver, and also adipose tissue or fat cells, and to instruct those tissues at a long distance away from the muscle to do things. So one of these hormones is called interleukin-6, and the more you exercise, the more interleukin-6 is released into your bloodstream from muscle, which is really cool. And then that interleukin-6 floats through the blood just like insulin does and regulates blood glucose levels and also the glucose regulation in these 3 different tissue types. So that's really cool. It's revolutionary and explains why exercise is good for us. Exercise promotes the release of hormones from muscle, telling other organs how to work. Okay, another thing exercise does is influences our fat cells. And what's really cool is that fat cells also release hormones. And this slide shows several different ones that come out of white adipose tissue or fat cells. As an example, adiponectin can influence obesity and diabetes, which is relevant to these kind of things. And exercise can actually directly influence which of these hormones out of fat cells are being released. And again, these hormones then float through the circulation and influence function of other organs. Therefore, exercise is really good because it affects both our genes and also the release of hormones into our body that have good health benefits. So this leads us to the next question I said I'd talk about, and can the Canadian healthcare system adapt to support patients adopt a more physically active lifestyle? And I really think that we can, and I think that certain provinces are moving in the right direction. Ontario being one of them, I think, is moving the right way. According to the Canadian Diabetes Association, what we know is that most diabetes healthcare teams are made up of doctors, registered nurses, registered dietitians, and diabetes educators. And depending on what province you're in, diabetes educators might be physical activity specialists, or they might be have some of these other backgrounds. But unless they specifically have a physical activity background, a major issue facing the healthcare team is who provides the information about physical activity. And there's a lot of evidence in the literature from the last decade showing that most healthcare teams that deal with diabetes lack the skill or the background knowledge to be able to prescribe exercise effectively. And that's a major limitation. So, as an example, do nurses understand what dose of exercise is required? Some of them might because they've taken additional training, but there seems, based on the literature, that a lot of them feel uncomfortable to be able to do this. And when they feel uncomfortable to do this, they actually tend to focus on the things that they know best and that they can address best, and then spend a significantly less amount of time dealing with physical activity. And like I said, there's a lot of data showing that. So this asks the question of how do we address that limitation? Can we add somebody to the healthcare team that has a specific expertise to prescribe exercise, and that'll be their primary focus? And this is one of the areas that there's been a need identified that some provinces are addressing and others have not done that yet. And in Manitoba, we're actually currently well behind some places like Ontario, and that we don't have physical activity experts on our teams here yet. So I've taken this slide from the Canadian Heart Health Strategy and Action Plan and adapted it a bit with my arrows at the top. So the bottom part's the action plan itself. And there's really three major segments of healthcare system: health promotion, primary care, and secondary care. So the question is where do various interventions actually have a place within these three areas of health promotion, primary, and secondary care? And the way that I see it is that sufficient physical activity is really in the health promotion or disease prevention section, which is also the location I think that nutrition, appropriate nutrition, will have its most influence, which is then followed by a lot of the primary care things where people are now clinically sick, seeing doctors, and they need to be screened or actually receive acute and chronic care. But interestingly, if we look at cardiac rehab, based on the evidence we have from that area, we know that physical activity and nutrition can also be interventions to be able to treat diseases after they're established. And in diabetes, there's a lot of evidence showing that lifestyle interventions at this point in secondary care is really, really important. And I've presented some of that to you here today. So how can we go about creating a team to be able to do this? Well, we all know medical doctors, nurses, medical assistants, and other players in the traditional medical areas are really, really important. And clearly their expertise is warranted and highly regarded. We also know that dietitians have been integrated relatively well into most provinces and their healthcare teams that deal with chronic diseases. And dietitians are light years ahead of kinesiologists or physical activity experts in the fact that they have a national certification program and there's actually registered dietitians. So probably because dietitians were smart years ago to be able to get a national certification program, they've been able to integrate relatively well into healthcare teams, which leads us to the physical activity experts, which I like to use the term kinesiologist for a few reasons. One of the most important ones is that the Ontario healthcare system has been relatively nimble in the last 5 years and is currently, under the Health Act, bringing in the College of Kinesiology in order to regulate the field of physical activity prescription. And this is a really important initiative because what it's going to do is establish kinesiologists as the person or as a team member that can prescribe exercise most effectively on a team, because their primary role will be with physical activity. And then the advantage is by bringing in the medical team, the dietitians and the kinesiologists, we've then been able to address the three pillars of diabetes care, being activity, nutrition, and pharmaceuticals. So Ontario should be commended for bringing in this College of Kinesiology. It's still probably years away before it's actually instituted, but they're well along in the process now, so hopefully in the next few years something will come of it. So I've covered a lot of material. I've been able to do it in about the 50 minutes that I was hoping to do it, or close to it anyways. But here are the take-home messages I think are really important for people to take today. First of all, a lack of physical activity may be the most important risk factor influencing the prevalence of diabetes today. Therefore, if we have interventions that can improve the amount of physical activity people are doing, we have an opportunity to be able to improve their health. Okay. Second of all, there's evidence showing that exercise therapy is a cost-effective intervention to improve glycemic control and also reduce cardiovascular risk in diabetic patients. Okay, so it's important that when we look at developing new initiatives that they're actually cost-effective, because none of us wants to pay more taxes, right? So exercise therapy appears to do that. The next take-home message would be my simple messages about prescribing exercise. So any physical activity is good, more exercise is better, and physical activity should be fun, otherwise people won't do it. Okay, and those are simple as we can get the messages down. Okay, and then finally, it's important that healthcare systems be designed in a way to build as well as support the capacity of primary care providers to prescribe and promote physical activity as a health intervention. And really the multidisciplinary specialist team approach that's been utilized in a lot of chronic disease models is the way to go for diabetes care, as well as for any of the chronic diseases that we can think of, cardiovascular disease or others. So really getting the right specialists working with the patient at the right time will allow the team to be more effective in actually improving patient health. Okay, which takes me to the end of my talk. It went by pretty quickly. I'm surprised that 50 minutes goes by so fast, but I'm more than willing to take some questions and try to answer them the best I can.
So if anyone has a question, you can either type it in the chat area now, or you can use the hand raise tool and we'll address your questions in order. I see Fran has a question. You can go ahead. Fran, do you have a question?
She typed it in, Susan typed one in the text there, so thanks, I appreciate that you thought the presentation was good. What I can do is, I believe the University of Western Ontario will have access to the presentation in their archives, but I can also provide a PDF file to the university, which then they can give you access if that's what they like to do.
Go for an interval training.
Angela, you can go ahead. Angela, did you have a question? You can go ahead.
Okay, so there's a couple of questions that are in the chat right now. Let me start with Greta's. The seniors question is really interesting. A lot of seniors worry about exercising at really high intensity. In particular, when we work with the cardiac patients trying to do some of the interval training, they don't think it's a good idea at first, and it's a matter of encouragement. What you can try to do is get them to do short bouts initially and try to build up their confidence. So rather than going from what their normal program would be and then telling them that you must sprint interval 1 minute and then rest for 1 minute for 30 minutes, maybe they do one sprint interval while they're on the bike or one sprint interval when they're on the treadmill. See how they feel, and then you convince them to progress up more and more. And maybe by several weeks or months, you convince them that it's actually a really good strategy. Okay, so I'll also answer Joy's question. I've heard of the PACE program, and it's used a bit in Manitoba. It's interesting because there are some aspects of behavioral change in it. What we found in Manitoba is that it's not very context specific for some of our Aboriginal populations. And Manitoba is a very interesting political situation in that we have one large city and a lot of rural communities. And basically there's a city of 700,000 being Winnipeg, the city of Brandon, which has 100,000 people. And we find our programs work well in those two cities. But when we move it into a rural context, where the next biggest city is only 20,000 people, that the PACE program doesn't necessarily work quite as well. But in our cities, we are using it. I think the source, well, what I try to do is put the sources of my slides on, or of my graphs on the bottom of each slide. So if you can get access to the PDF that I'll give to Western, you can probably look up a lot of the papers. If there's no reference, it's likely that either I got it off of Google Images or I made it myself. I believe the one about the risk factors that you're talking about, where it shows so many people at risk, I actually made up on my own. So just find some primary data and then make your own graph is what I would suggest on that one. But I don't mind if you use it, if you reference my presentation, if you take it directly out of the talk. Francis's question about are there studies available about the best ways to structure lifestyle management programs and how to actually keep patients compliant? That's a really important research question and probably $1 million question, really. A lot of the things I presented today were pulled from different studies, and each of them tends to build on each other. What we know is from some studies that a 6-month intervention is ideal if you want to change behavior because you give them supports for a significant amount of time. The problem with it is that a lot of people don't like being in a program for 6 months. Alternatively, the cost is higher if it's a 6-month program versus a 4-month program and other things. I would suggest taking a look at the DARE trial, which is the study I looked at, or I presented about the aerobic exercise training in combination with resistance training. The DARE trial was really interesting. And if you look at that CNN study where they looked at combination therapy, that study was just published today in the New England Journal of Medicine, I believe, or the Journal of American Medical Association, one of those two journals. But the CNN webpage will have the reference to it. And based on my knowledge of those two programs, they are best practice, so they'd be a really good spot to start. Kim's question about are there different recommendations about how much time should be spent participating in exercises for seniors compared to the rest of the population? I believe there is. The resource I would use would be the Canadian Society for Exercise Physiology. They actually have physical activity guidelines published for youth, for adults, which should be anybody between 20 through 60, I believe. And then they also have one that's specifically tailored for senior aging population. And the Canadian Society for Exercise Physiology is one of the major consulting organizations for the Canadian Physical Activity Guidelines. So they'd be the expertise or the experts that I would refer you to for that kind of document. Are there any other questions?
Okay, if there are no more questions, we'll wrap up now. Thank you, Dr. Duhamel, for doing the presentation. It was very great, very informative. If anyone would like a certificate for participating in today's presentation, if you go to the homepage for the webinar where you access the link to the launch page, you'll see a link to a quiz. Once you complete the quiz, the certificate will be made available. If you have any questions, you can email me. I will put my email in the chat area for you to write down.
My email contact's also listed on the first and last slide in the presentation. So if anybody wants to contact me about questions, because I saw there was a couple that popped up, feel free to contact me and I'll try to respond in an appropriate amount of time.
Okay, thank you again. And to let you know, our next webinar will be scheduled for January 12th. We will send out another email to keep you notified, but that's all for now.
Thank you very much for attending today, too. I appreciate the chance to talk about this stuff.